next session is on Remote Healthcare is the Future of Medicine by Dr. Ganapathy, the president of Apollo Telemedicine Networking Foundation. Dr. Ganapathy is India's first neurosurgeon to get a PhD in neuroimaging. Sir has done his MBBS, Masters, various fellowships, and PhD from Madras University. So back then, when Sir went to the administration, Sir, the clerk of the administration asked him, "Have you not passed yet?" Sir has published many articles, authored many textbooks, given lectures, and received various awards. By the time I read the entire credential and achievements, Sir's session will be over. So I welcome Dr. Ganapathy for the session.
Everybody, at the outset, I wish to thank Vishy and the organizers for putting together this excellent program. I don't know how many of you recollect that 2019 is the last teen year of this century. I think it's most appropriate that from our teens, we are entering into young adulthood. I remember in 2000 when I first got into telemedicine, how the world was and how it is today. I believe now that we are reaching that critical mass so essential for a successful takeoff. Now, I'm going to start from the very end. The take-home message of my talk is going to be summarized in 3 statements, which I'm going to show to you with solid examples over the next 1,200 seconds, that today, telehealth, digital health, M-health, E-health, I-health, whatever you call it, is no longer pilots. 20 years ago, I used to say that there are more pilots in telemedicine than in the Indian Air Force. I also said we all suffer from a condition called pilotitis. From that, we went to the stage of POC, or proof of concept validation. From that, today, telehealth is reaching the stage of being integrated into the primary core of the healthcare delivery system. I'm extremely grateful to you, Dr. Ratanji, for pointing out that primary and preventive care is the most important, and I'm going to show you how technology can help achieve primary and preventive care from a distance. Today, distance has become meaningless. Geography has become history, and I'm just going to show you a few selected examples to show that we are actually doing it. You're all familiar with all this, the urban-rural health divide, the lack of doctors, lack of hospital beds, etc. Now, I strongly believe that a solution is not a solution unless it is universally available to everyone, every time, everywhere. Quality healthcare confined to a small percentage of the population doesn't mean anything at all. Now, just a word, because this is a mixed audience, what exactly do I mean by telemedicine? The process of telemedicine, obviously you require, I'm old-fashioned. I still would like to call it a patient. I still would like to call myself as a doctor, unlike most of you people here who talk about the healthcare industry. I'm sad in a way that the healthcare has been delegated to an industry in the sense that the good old doctor-patient relationship is slowly going away. Healthcare has been taken over by people like you, but that is why there is progress. I mean, I have to admit that if you people had not taken over healthcare, there would still not be progress. Now, having said that, this is what the whole process is about. We require hardware, we require software, obviously you require connectivity. This is self-explanatory. And now, in the last year or two, we are going to be more and more conscious of compliance and adherence with regulations. The Telemedicine Society of India is actively working. We hope in a year or two, if not the Telehealth Act of India, at least regulations are going to be notified so that medico-legal problems will not be an issue. Example number 1. I visited this place twice, and this is the reality. This is India, the real India, not these air-conditioned rooms with all these fancy things which we are doing now. This was exactly how our car went. And before we intervene, this is a photograph of a burns patient being dragged. You can see how it is. It was impossible for the government of Himachal Pradesh to provide health care in the district of Lahul and Spiti, population of 34,000 people. And then we took up the challenge, and about 2-3 years ago, we decided. Now, I just want to illustrate with a specific example. 7 cases of myocardial infarction at a height of 14,500 feet, temperature minus 25 degrees, landslides everywhere, the valley cut off completely. Through a dedicated VSAT supplied by BSNL, we did an ECG. My doctors are excellent. Though the ECG was normal, my doctor said, I don't like the look of this guy. He's not doing well. Keep him there. Don't send him. 45 minutes later, we repeated the ECG, picked up a myocardial infarction as it was evolving, and initiated thrombolysis from a distance of 3,000 kilometers. We have done this to 7 patients. Supraventricular tachycardia. We run the world's only tele-emergency services. This has been published in a peer-reviewed journal. 1,000 cases of tele-emergencies 24/7 we have run. Now, Mr. Ratan, again, this is where I'm coming to you. So please don't, I'm delighted that a quaternary care hospital, Apollo Hospital Group, which is known not for a heart transplant, not for a liver transplant, that is routine now, but for a combined heart and liver transplant, that hospital today is involved in proactive primary care. My staff go make house visits at this at this remote district, and we have done, using technology, more than 4,076. This was a relatively older slide. We go to everybody's house, get a random blood sugar done, get an HbA1c done, get a hemoglobin done. Simple thing like anemia. 58% of women are anemic. All it takes a drop of blood. That's all it takes. So here is an example of technology used in preventive and promotive healthcare. So this is the message. Now, again, you can see, we tried to put quality care. This is like a JCI accredited hospital. This is a very interesting story. With a lot of difficulty, initially, I vividly recollect, I made a presentation to the chief secretary, was not at all very keen on, without a tender. Then we said, please give us a chance. And then we got an appointment basis. After 2 years, a tender was floated. Nobody, we were the only ones who applied. Government rules, they cannot give it to us. A third time they put the tender. Again, nobody applied because it's very difficult. And it is not the ROI, or intangible benefits, the happiness and pleasure we get at having made a difference in the lives of a few thousand people. And using this as a role model for the rest of the country, for the rest of the world to do. From a purely return on investment in terms of materialistic terms, certainly there's no ROI. But all of us are delighted. The numbers speak for themselves. This is, and just see, 12th February. Theoretically, I could have got my statistics even this morning. But becoming a little older, I'm becoming a little lazier. This is the technology we use, real time. It is totally paperless, totally digital. You ask me any question, and from my smartphone, I can get every single detail of what you want. This is modern technology. Now, as a scientist, I believe there has to be evidence. Without evidence base, nobody is going to believe. If I'm going to ask the World Bank for $100 million, they're going to ask me, where is the proof that your intervention has made a difference? Where is an impact study? Where is an impact analysis? So with all this in mind, we do an enormous amount of documentation. Any question which the government asks, we are able to answer. We are proactive. We are transparent. And we believe in science. Because of my background, probably, we believe in scientific study. So that's one sample. Unfortunately, I require several hours, so I'm cutting short the time. Now, this is another one. 164 electronically augmented primary health centers with Hyderabad as our major command center. A few kilometers from here is a medical response center where we have 120 doctors, paramedics, nurses, etc. Many of them available round the clock. And this is all available in real time. The Chief Minister of the State, the Principal Health Secretary, all authorized people are able to evaluate this at any time. If I had the time, I would have just clicked onto this, and you can see it getting updated. As I'm talking to you now, there are people maybe about 20 to 30 people entering the primary health center every single day, 6 days a week. So this is an example of technology being used to provide secondary health care in a primary health center. My orthopedic surgeon, my neurologist, my cardiologist appears on a giant TV screen within 2 hours max of a patient entering a primary health center. Gone are the days when from a primary health center, you had to go to a taluk headquarters, community service, district center, and then finally come to NIMS or something like that. Today we can provide this wherever you are. Just look at these numbers. This was day before yesterday. On 14th of February, we have 59 lakhs, 5.9 million, more than the population of Singapore. These are the people who have availed of the services in these electronic primary health center. And I'm absolutely delighted that the government, based on this pilot project, have got funding from the World Bank, and a tender has just been floated for 6,500 primary health centers which are going to follow this model. And eventually, over the next couple of years, I'm absolutely certain other governments are following suit. We have just started a project in Jharkhand yesterday, in Uttar Pradesh, so many states. Public-private partnership is happening, and what the first speaker spoke about is going to become a reality in my lifetime, not decades from now. And look at this, specialist teleconsultations. 10% of all the people who came to a primary health center had a specialist teleconsultations. And laboratory, we don't stop with just taking the history and making a clinical diagnosis. We are scientists. We like evidence, proof. We have ECGs. We don't have echocardiograms yet. We have HbA1c in every primary health center. And we are paranoid about quality control. I'm not aware of any organization anywhere in the world which do a scientifically valid tele-mentoring and a tele-monitoring of 164 laboratories from Hyderabad alone. We have a fantastic team, and you can see here 5 lakh people who have utilized lab services, pathology, microbiology, etc., etc. All these investigations, the reports, computer-generated reports, are given to the patient on the same day. I challenge anyone in the country who will be able to do this at a primary health center level. And all this is totally free so far as the patient is concerned. We all blame governments. We say the government is useless. They're doing that, they're doing this. But they're not doing that, not doing this. But here is an example. Third illustration. We took over existing 115 vision centers. It is called the Mukhyamantri Eye Kendram centers. 8 lakh patients have already used this. We have 115 centers. Every single center, we on an average get about 20 to 30 patients. 30 ophthalmologists based in Chennai. Look at the fundus. They peer into the interior of the eye of people who are coming to rural Andhra Pradesh. All this is scientifically valid. Look at the dashboard 3 days ago. 7,86,000 is the total number of visits. Spectacles, 6,15,000 spectacles. It's mind-boggling numbers, but we are still able to do it. We are now in advanced negotiation. We hope within a year from now, or maybe this year itself, we will be able to get drones to deliver spectacles, because we are finding it difficult now to go into the interior part. These spectacles, everything is done with tele. Please remember, we do not have qualified optometrists. Forget ophthalmologists. We don't even have qualified optometrists. We have what the government of Andhra Pradesh has recognized, a new entity called PMOO, and using that they have been trained. They are handheld by optometrists and ophthalmologists from Chennai, and we have not had, to the best of our knowledge, a single problem. We have not made a wrong diagnosis. We have not caused any problems, etc. Now, this is the numbers speak for themselves. Example number 3. Now you can see the fundus image transmission. So the fundus images are uploaded. That is my reading center in Chennai. We look at this, and again this has been presented in international conferences, as well as papers have been published in peer-reviewed journals. Fourth illustration, corporate social responsibility from a multinational company. Over the last 3 years, we have done a screening of 8.5 lakhs. As of 23rd January, I just didn't bother to get the latest slide as of today. And the numbers speak for themselves. We do it in different parts of India. And here you can see teleconsultations in camp mode. The paper has just been accepted for publication by the leading journal of the world, Telemedicine and e-health. So what do? We don't, camps, I mean, I'm not too much in favor of camps, because in camps you make something and that's the end of it. There's no point. What do? Then and there, in real time, all this is by SOP. We have standard operating procedures, protocols. All my staff are very, very well trained. So when somebody scientifically, World Health Organization classification fits into pre-diabetes or diabetes, we offer him a teleconsultation then and there. And in Hyderabad, I have Hindi speaking, Gujarati speaking, Tamil, Malayalam, etc. speaking people who answer these questions. And you can see this. This is the exact process: height and weight measurement, obesity, that, this. Technology is used in a large scale. Illustration number 5. This is NTPC, National Thermal Power Corporation, a Ratna, 10 Ratna company. This is the Bongegong is in the remote rural Assam, just about 20 miles away from China. It's a very disturbed area, officially classified as a disturbed area, terrorist activity, etc. It was actually considered as a punishment posting. And at one stage, the executive director was wondering whether they should close down this thermal power generating factory purely because health services was zero. They were unable to get doctors, nurses, nobody. Doctors who came for various reasons would go away. It was considered a punishment posting. We took up the challenge. We established a telemedicine center. Today we have an excellent center. We have about 4 beds now. We have 2 of our own doctors posted there. We have done, the numbers speak for themselves, you can see. And we have very recently installed an X-ray as well. We do teleradiology, telephysiotherapy, tele-counseling, tele-education. Everything is tele. That's what we do. Teleradiology services. Again, the government is our client on several occasions. It is very difficult to get radiologists with a turnaround time, a guaranteed turnaround time 24/7 of 60 minutes. A qualified radiologist reports this, and this is what is happening. These are various other projects, Uttarakhand, Jharkhand, etc. Bhopal Smart City, when I made this slide, it was to begin in 10 days. It's already fully operational now for the last 2 months. You can see this very innovation. You were talking of innovation. This is what moves from one road to another road. On Monday, 5 p.m. to 8 p.m., it's in one road. Tuesday, another road, and so on, so that the people can get teleconsultations. You can see the VSAT on top. Very recently, and this was our first international collaboration with a very well-known University of Pittsburgh. This project is entirely funded by the University of Pittsburgh in a very remote tribal area in Gujarat. Just about 10 days ago, we have started this. This, of course, is using modern technology, ultra-modern technology, where we are able to get a lot of people together. Now, when we talk of remote healthcare, it's sexy to talk about rural healthcare. I don't think it's a crime at all to provide good modern healthcare to people living in the heart of Hyderabad city or heart of Madras and make some money out of it. Why not? So this is India's largest EUPHC in Apollo Hospitals, Hyderabad. The figures speak for themselves. Huge numbers, more than 120 intensive care units from different parts of India are connected to the EICU, and this highly qualified group of intensivists advise the people there. Of course, we also have tried to record all this, and I'm delighted that we have been used as a case study to illustrate global practices. Wharton, Harvard Business School, Yale Institute of Management, and we've been quoted also in Harvard Business Review as an example. And very recently, Columbia University, which is ranked as number 9 in the world, they came to Madras, they spent a few days, they took a video, a 45-minute video, and today we are used. Questions are asked about us. As in the question paper at the recent master's degree in public health international relations, SIPA, School of International and Public Affairs, we were asked a question. Can you switch on that video, please? So I am also obsessed with time, so that's why I hope I did not wait till the second or third bell rang. So ladies and gentlemen, challenges. Can you switch on that video, please, on the right side? Challenges, I mean, the punch of my presentation is gone because the video is not there. Doesn't matter. Just switch it on, please. I told you in the beginning. So challenges are what makes life interesting. Or switch on the video directly if you are not able to. I remember reading long ago. See, this is a classical example. Technology in search of an application is doomed for failure. Technology is an enabler to achieve an end and not an end by itself. So it doesn't matter. The video doesn't come. Had the video come, sound please. I rehearsed all this before I came, but this is again classical of Murphy's Law. I have a message for this. Let me convey that message to you. When I was a medical student, as a postgraduate, as an assistant professor, as a father, as a grandfather, I was taught that when a child cries, it is because the child is hungry, nappies are. I never thought, the video is not complete, no, it doesn't matter, it should have. I never thought that in my lifetime I will see in the differential diagnosis of a newborn baby crying, it is being taken away from a mobile phone. That video is actually 1 minute long, and it's a double-blind, randomized, controlled crossover study, because there were 3 instances where when the phone is given, the baby stops crying. When the phone is removed, the baby starts crying. Scientific evidence that this is what happens. So this is the real world. So I think it will be a shame if we do not use technology properly to achieve and bridge the urban-rural health divide. Again, as I said, for lack of time, I'll be very happy to interact with any of you for any specific question. Thank you once again for this opportunity.
Thank you so much, sir. Any questions?
I was telling that thank you for all the initial words on the non-practitioners. Okay, so my question to you is, we have seen a lot of disruption that is being created across the healthcare space, which is on the positive side, which Apollo is doing. Okay, let it be 2007, the start of Apollo units, then the Health Street, and then all the telehealth and telemedicine work that you are currently doing, which is far more better than many of the modern countries are doing it. So you have quite a lot of information that is available to you, which are millions and millions of records, which many companies would pay billions to get it. So what is that going to be used at? Because the predictive analytics that you're going to create out of it is going to be very, very valuable.
You're absolutely right. The IT department for the Apollo group is pretty strong, and I am not directly involved in it, so I couldn't answer you in minute detail. But I do know we have an AI group, artificial intelligence group, predictive analytics. Work is being done, and I do know that it's in the public domain, that there is a formal collaboration both with Google and with Microsoft, and clinical applications have already started. All patients coming for master health checkup in 3 or 4 of the major Apollo hospitals, Google's predictive analytics is being used. We have just started doing this on a regular clinical work also. We are fully aware of it, and obviously we will be exploiting it and making use of it to the maximum. We have an in-house, a very strong in-house IT department.
Dr. Ganapathy, congratulations. Very, very energetic presentation. I think all of us get motivated with your presentation. Thanks a lot.
Empty vessels make the loud noise, sir.
It's not empty vessel, I know that. Telemedicine is the only solution, I personally believe, is the solution for a country like India, where the number of healthcares and not only professional, but the resources are a problem. We can't produce even a number of doctors which is required in next 25 years. So we should not look that direction, and what you have been doing is tremendous work. My question is that, what is your prescription to reach out it faster to the larger population? Because you have done to some places, some states, but a vast majority of places is still remote.
Thank you for that good question. I have never been a diplomat in my life. I call a spade a spade. All of you have heard of Wi-Fi. All of you have heard of WiMAX. I don't know how many of you have heard of YFM. This is a terminology which I coined maybe a decade ago. If anybody in this audience can solve the problem of YFM, I think telehealth will become integrated into the healthcare delivery system. What is YFM? Capital W, small I, capital F, capital M. What is in it for me? Let's not be hypocrites. We are the world's biggest hypocrites. The only thing, unless you are like me, a very senior citizen, 20 years ago, 30 years ago, I mean, though I got into it, maybe I'm slightly mad, that's why, no 30-year-old, 40-year-old, 50-year-old physician will get involved in telemedicine, telehealth, unless there is vitamin M. It's a fact of life. We do not have a business model at present. Unless we have a business model where the income is significantly more than the expenditure, nobody is going to embrace it. At the moment, telemedicine is being used with a carrot and a stick. There is no, which CEO? A CEO is given 10 crores. You are the CEO, the CFO of the hospital. Will you use that money to put up a laboratory or a CT scan where you're guaranteed ROI, or an open heart surgery or a kidney transplant or something? Or will you put 10 VSATs on top of your hospital and have mobile hospitals with a VSAT on top and go around the villages? You tell me honestly, will you do that? No. As everybody wants beds to be occupied, everybody wants theaters to be occupied, the previous speaker gave a very detailed discussion on various things. So unless, which is not wrong, which is fair enough. So unless we develop a system, and according to me, and this has been proved to some extent in the US, once Medicare, Medicaid, the Veterans Hospital Administration recognized teleconsultation for reimbursement, the number of teleconsults went up like this. Once a state government, a central government, public sector undertakings, health insurance, everybody pays me for a teleconsultation. We have somehow been able to get on with this. One of the secrets we do is we do telecamps. So what I do is I get 10 orthopedic patients, one after the other. My consultant is not going to take 150 rupees. No. I mean, in today's cost of living, no. But if I get 10 orthopedic people together, I give him 1,500, which is a little more, He has seen 10 people, but that doesn't matter because as a doctor, I get a kick out of seeing more patients. The only difference between me and Mukesh Ambani is the 10 zeros he has in my bank account. What is the difference? 10 zeros. I have 1 lakh, he has 10 lakhs more. Not 10 lakhs, 10,000 lakhs, 100,000 lakhs more. So this is the only difference. It is numbers. It is a number game. So you cannot do this unless everybody are well compensated. And telemedicine has not yet reached the stage where a medical doctor can be totally dispensed with. So till such time, the business model has not been solved. Unless that is cracked, we will continue to make presentations like this. We'll continue to clap hands. We'll continue to... But it's never, I always say there is no stethoscope society of India. Similarly, I don't personally, though I started the Telemedicine Society of India 20 years ago, personally, I wish in my lifetime the day comes where there is no Telemedicine Society of India. A telemedicine should be a part of a cardiologist, neurologist, rheumatologist, sexual medicine. Every single should embrace telemedicine. It should not be considered a discipline as a separate subspecialty. So please tell me, sir, how to pay, how to give money, how to get profits. My CFO is not interested in funding me. I was the only loss-making department for 17 years. Thanks to the wisdom of the management, they let us go. It's only in the last 3 years, because of the fantastic progress we have made, from loss we have become 0-0. It's not minus anymore. Thank you.